everyone. Good I wish your eyes just worked like they always work. It'd be much easier, wouldn't it? Morning, everyone. Welcome to board. I'm just going to take some apologies. I don't go into anything else. So we have apologies from Precious, who's not very well today. We have apologies also from apologies from Ian Reckless. Ian, I don't know. So I was coming to the execs. I think I've got apologies from the non-exec. Apologies from Sarah, that's where I've got apologies from, and then apologies from Ian, who's I think is just going to look at the screen as I'm speaking to see if my sound is travelling to Tom. Yes, he's nodding. That's marvellous. So we have got the proper speaker working today. Hopefully, Tom. So hopefully that's good. So I'm just going to make some welcomes. I'm just going to be patient.
All keen to get going.
Yes. So welcome to Hamid, who's our medical director today at board, in place of Ian Reckless. Welcome, Hamid. Do you know everybody?
Most people.
I'm one of the non-execs.
It's the last week's for their briefing.
A couple of self-governing rooms in the corner, which I will mention. And then would you like to introduce yourself, Tilly?
Yes, hi everyone. My name is Braden. I'm shadowing today.
And I was just going to say, I'm sure we'll mention it more at the end, that this is Dev's, sadly, Dev's last board meeting. That's cheering, Dev. And we have, I think, 2 people with us online. Is that right, Timmy? Am I looking at just 2 people online? Just so it sort of helps to count. So yes, marvellous. Okay. So if everyone's happy, we're all in the room, we all know each other. I think we can kick off. We've got quite a busy agenda, so we're going to try and sort of promptly our way through the items, but obviously have appropriate enough conversation where we need to. So are there any declarations of interest, any new interests? Or any interest to declare in terms of items on the agenda? I haven't got Ian, so we won't be having that one from Ian today. Just to mention the register of interests and just to remind people that it's an open document and can be updated at any time. So if anyone ever wants to make an amendment, they should go ahead and do that. Lovely. I don't think I've got anything else on the opening officers. I just want to mention to us that in a week's time, I think 23rd and 24th, it is the Nursing Support Workers and the Maternity Support Workers Day, and National Day. And we are going to welcome some support workers to our room this morning. Fiona, you, I think, just want to say a couple of words, don't you?
Yeah, so it's an interesting choice, thank you, Chair, being asked to bring staff and patients into the room and think very carefully about who to bring. Our healthcare support worker workforce has a fairly large vacancy in comparison to other workforces within the trust. And there are lots of factors that influence into that, such as hours and warehousing, pay rates, external trust, etc. But it takes a specific type of person to choose to come and work in healthcare and work as a healthcare support worker. And they're often a forgotten role, but a really key part of our workforce. So it's very tempting as a chief nurse to want to bring in all our shiny advanced practice and all the exciting roles that are going on. But I felt with our healthcare support worker and nursing support worker day coming up, it was a nice opportunity to bring them in, to explain their role. Some of them are really exemplary. They go way above what it was expected of them. They take on extra roles. And so I wanted to bring that in, and also to recognise that as a trust, following pressure from the unions nationally, we have taken part in the Band 2 to 3 uplift. So this is a workforce that has been on our minds. We're just finalising this month that change in pay grade for this particular workforce. So I just felt it was an opportunity to bring a group of people in who the board have had focus on and to share their experiences, etc. They're very nervous, so they're coming with a matron who's going to do it as a question and answer session just to help pull it out. So we're worried about remembering things. So I have 4 healthcare support workers that I'll go.
And where are we going to put them?
They're going in the corner. Oh, don't expect me help.
Okay.
Yeah, they're going in the corner just there.
Well, they go right there. They'll be happy. They're going to exclusion at the back of the room. Feels a bit.
I think it's
much
to do
nicer
with the camera. I mean, I'm
Oh,
happy
I
to bring them
see.
in and up here, and it's fine.
Let's put,
Yeah,
let's
everyone's-
put them
I'm
somewhere
just
else.
going to disperse them.
Yeah, let's put John in the corner. That's a good thing.
So
Let's go.
Sure, there's a film reference in there somewhere.
Yes.
I'm standing. I'll stand in. I'll film.
Oh, cool. Sweet.
Nobody puts John in.
Nobody puts baby.
Under item 11, there's an annual patient experience report, but there was an annual report that came to the last board, and the annual plan is going to go to the quality committee on the 9th of December. So I'll bring the forward plan back in January. That's okay.
Good morning. Good morning. Good morning. You can stand or sit, whatever you feel like you'd like to do.
Yeah.
You want to sit or? So, good morning all. Very nice of you to be here. It may look like a very big group of people, but I promise you we are all friendly. We come in peace. I wonder whether you just like to share names.
My name is Sarah.
Excellent.
I'm an SCA on Ward 23.
Very nice to meet you.
My name is Makaya, Asian Morton.
Very nice to meet you.
My name is Winnie. I work in Ward 17.
Very nice to meet you, Winnie.
My name's Cameron and I've got Ward 22.
And so,
I'm Alex. I'm the information surgery, and I just gathered everyone together today. So
you might not know everyone around the table, but what you've got around the table is a mixture of executive directors who run the trust on a day-to-day basis and non-executive directors who work as part of the board for what we're doing and how we can make things better for patients, better for staff. So we all sit here with those hats on really, as owning whatever our expertise. We've got finance people, we've got HR people, we've got people who are used to operations. We all are part of running the whole of the trust. And we know in a couple of weeks' time, or a week's time, I think, no, a couple of weeks' time, get my dates right, that we've got the Healthcare Support Worker Day, National Day, and then Maternity Support Worker National Day. You guys are an absolutely critical part of this trust. And we know you work incredibly hard to provide a great patient experience and make the wards and all services in the hospital a fantastic place. We don't hear enough from you. You know, we're always hearing from nurses and we're always hearing from doctors, and we really are pleased that you can be in the room with us today. So try not to be nervous, because honestly, you're just people, and we're really happy that you Marika's here. We don't write. So I'll hand over to yourself, and I think you're going to do this as a bit of a Q&A. Is that right?
yes,
Yeah.
bit of a chat amongst ourselves. There's some things that they want to talk about. So I'll probably just start with some questions just to promote some of that, and give all the opportunity to ask a couple of questions. And if we're talking too long, just give me a little wink. Yeah, well. All right. So I think one thing that we talked a lot about was why you love your job. So I'd really like for you to start, Sarah. I think just tell us why you love your job.
I love my job because I feel like I can make a difference. For example, somebody comes into the hospital negative fracture, and I realise that if they're anxious, they're worried about what's happening, I can be there to support them and give them encouragement and to see the progress after giving her surgery, getting back on their feet, and the ultimate goal of going home.
And I think you've got a bit of a special area of that expertise, haven't you, Sarah, on the ward? Do you want to think of it?
Yes, I'm the end of life champion on the board. I have a very strong passion about food end of life care. feel it's really important, and also feel privileged to be able to do the last offices for patients that have passed away.
And you support the whole thing with that, don't you?
Yes, I do. I support them, the nurses and the HCAs as well. Because sometimes it can be quite upsetting for people, you know, to give them support and reassurance and to show them the correct way of doing things.
They're not quite difficult for things.
Yes, but it's really important to me.
That's really important to patients, isn't it?
Yeah.
And to the families.
Yes, I've definitely found that as well, yeah.
And I think we talked a little bit about the fundamentals of care in terms of the healthcare system. And Kaya, you touched on a little bit of how personal care is fundamental, but some other things that you might support with on board. What should we talk about?
Yeah, we support analysis with HCGs, bladder scan, all quite a lot of things which help our nurses with, because they are often very busy. So stepping in, you always and so on.
And they're extra skills that you pick up through your time working towards.
Yeah, I've got. Sorry. Yeah, I do learn a lot on the board, to be honest, from patients and my colleagues. So it's a very, very passionate.
And you have to work quite closely, don't you, with your nursing on board?
We need to communicate every time so that the patient care will be very effective. Without communication, we can't actually do. So we have a very good communication process.
And Cam, why you talked a little bit about your time spent with patients? Why do you think that's so important for families?
I think for us, we get to know the patients better than everybody else. So we're, more hands-on with the patient, but then we get hands-on with their family. So then we get to know the family, we get to know more about the patient, and they sort of become part of us. And because we do spend more time with them, you just get to know them. And that's why I come to work. I come to work for, it sounds cheesy and but no, I generally come to work for the patient. I want to get better. I want to get to know them. And then, sometimes they can tell me something in confidence that they don't feel comfortable telling the nurse or somebody higher, because they haven't got the relationship they have, that they have with me. And they open up more, which I like. They like to get to know us as well. And as I said, yeah, they just open up more with us.
But they know you're in that space, don't they? That you're.
They feel safe.
Yeah.
And that kind of leads on nicely, Cam. What are the things that perhaps stop you having the time to do that? What are the challenges of the role?
I think the biggest challenge for us is, I've been here for 3.5 years now. I absolutely love my job, but throughout the trust, there is a problem with staffing. So I've done A&E recently, so I go and do back down in A&E. So I can see from the beginning how the trust is going to look, and now I have an understanding of how busy it can be and, escalating patients towards. But it has a knock-on effect everywhere else. So, for example, I run the gastro ward. They'll come on, we'll get a phone call, so we'll have 3 trained nurses and 3 HCAs. They'll say, can you send a healthcare assistant to ward 17? That's a cardio ward. Gastro. So you get taken out of your comfort zone, and then, I could go in the morning, I spend half a day with my patients, and then I've got to go. And then I've got half a day then to get to know a load of patients. I have no idea what I'm doing. I don't know the layout of the ward. But it's not just us. It's a problem throughout the trust. And obviously, if I have to move, I have to go support another ward, I'll do it, which is completely understandable. But I think that's one of our main pressures.
What does that feel like when you're in an environment that you don't, gastro, you don't know, say, cardiac, or whatever? What does that feel like?
Not awkward, because for me personally, it's a challenge in itself, because you have to walk around. So I got moved last week, for example. So I went to a ward I've never been to. So I'm walking in, and everyone's obviously cracking on with their jobs, but then I need to know where the stock rooms are. I need to know the codes to the doors. I need to work out the layout of the ward, where the sluice room is, and it's a bit overwhelming. And then you have to take a handover for all the patients that you're looking after. But yes, very overwhelming.
And sometimes you might get moved to an area that's just been opened, might you? So like an escalation area where no one knows everything. So I think it talks a little bit about those challenges.
Yeah, that's very difficult, because it's not staffed like a normal ward. So on a normal ward, like, you have your sister in charge, you have your nurses, but because an escalation ward is just a ward where everybody's picked off wards and you're just thrown in, it's difficult. But you just have to do your best. You have to communicate with your staff and communicate with the nurses, and then come up with some sort of plan and make it work. It's the patients, are at my best interest. So as long as I'm doing my job and I know they're safe, then
I think we talked a little about what if we could create a magic wand, what we would like for HCA to the profession, and really, I don't know whether you had anything we talked a little bit about.
Yes, as a HCA, I thought we are not only just providing care and respect, we are crucial. We have our highest resilience, and also we have a experience how to make ourselves stay professional to our role, because I witnessed some of patients when we came to my work, we are very worried about what's going on and what's happening next. If we are not staying a professional to tell them, give the confidence to them, they will be fine, because we are here to support you. It makes them very feel good. So that our role is very important. As say, sometimes they fear to tell the nurse what they think about, but they will share with us during the banquet, during the giving a quality time. It's a small things, but I think it's a very valuable and very precious. I say, and also sometimes we have shortage of manpower, but we still have to carry on our professional role in front of our patient, because they will feel safe. And also we have to promote the safe practice in our hospital. This is very important to everyone, for the patient and our staff. So for me, accountability is very important to everyone in our role.
Great. And we just one last thing. Marco, we talked about some of the challenges of being able to do your role how you want to do it. Just talk a bit about that.
Yeah, if I had the magic wand, like I said, I would like to change patient mentality. I know they're here to be taken care of, which I agree with that. But sometimes it's just like constant reminding to use taking care of them, like you're here, take off me, you're here. But I'm not here to work and I'm training my medicine. And then please bear with me as well, because I can only do what I can do. The abuse that comes with it and all that. Sometimes it's like you know, but then the support around you and all that, it makes you a bit like, sorry, you over. I mean, you just press all that, carry your bike and be very, very intimate.
Is that something you all face on a regular basis? Sorry, I'm back across you. Is that something you all face on a regular basis?
We talked about that night section, didn't we? Like there's the expectation piece, which has changed over the last 5-10 years. And then I think more recently, more challenging behaviours from patients without capacity rates across the board is a challenge. And obviously, as Cameron and the others touched on, they obviously spend the most time with the patients, so they are quite often at them receiving
the front line of that response from patients. Would you guys be happy to take any questions from people? Because I'm sure people have got things they want to ask. So, you can always pass it on. Would anybody like to ask? Joe. Do you know Joe?
I sort of know. First off, thank you very much indeed for coming in. Really, it's great to hear what you do. One of the assumptions that organisations can quite often make is, how do we train people? How do we invest more in individuals in order that you can progress in your career? Do you think we've got the balance right? It's one of those things, never ask a question as a chief exec if you don't know the answer. Well, I don't know the answer to this, so you've got a free hand. Do you think we've got the balance right between offering training and support for you to progress versus making sure you're happy in the role that you do, because you actually don't want, you want to continue to be a healthcare support worker rather than become a nurse? And the reason I ask the question is because my mum never became a registered nurse. She was always really happy in the role that she did, and people kept saying, why don't you get trained to do it? She's like, no, I don't want to. Have we got that balance right or not?
Go on,
think so. No. So I know some other trusts, they're a bit more proactive with like the nurse associate. So last year, so when I first started the trust, it was open. So I come in April 21 as a healthcare assistant. I did all my care certificate and stuff, and then the nurse associate scheme was there, but I just missed out. Then they said, "Oh, it's going to come back. It's going to come back," and there was nothing on it, and then it just sort of stopped. I think in 2022, I want to say. And then I went on to do level 3.
Can we just for the non-execs, can we just say a few words about the nursing associate and what it means career-wise? It's just what we're talking about. There'll be others in the room that don't know what you're meaning, so I don't know who's best to say.
I'll let Alex explain.
So you obviously have a registered nurse, which is at a band 5, and you have a band 4 role, which is a nurse associate role, and that role was more brought in as like I don't want to say old, but previously like your enrolled nurse. These were people that had experience in care. That were then supported in more of apprenticeship style learning to get to that registered level, and they fundamentally do work as a registered nurse, but more with under the direction of a more senior nurse.
So, sorry, Cameron, I interrupted you.
So then I did a level 3 in. What did you do in apprenticeship in health and social care? With the promise that if that was done, then the nurse associate would come back. I've not really heard anything, and I love my job. So I love being a healthcare assistant, but I feel as if I'm ready to progress. But this is where I'd like to support the trust. I own my own home, so I can't just say, "Oh, actually, I'm going to quit, go to uni," because I can't afford to pay my mortgage and my bills, and then be full time at university. And
I think that's why the nurse associate role was brought in, to try and support people that are really committed to care, that have real experience, that can't walk away from that.
Yeah, so as the new chief nurse, I feel very passionate about pathways into nursing and pathways for our career for all staff. And nursing associates is something that I've picked up since I started, that we need to reinvest and look at our registered nursing associate programme, which universities we're going to work with, and bring that in as part of our workforce, because working through from our current band 2, or soon to be band 3, all the way through to maybe the future chief nurse, that role is there and those opportunities are there. And to get to register, there are now 3 different pathways that can be taken. You can come through as a nursing associate and then do a top up. You can do a registered nurse degree, apprenticeship, and then become a registered nurse, much more appropriate and make a suitable career for yourself around remaining within the organisation and working on an apprenticeship, and then going out, so not bursary led at all, or you can go through the university pathway. So there's lots of different pathways. I want to straighten that, not just for nurses, but also for our AHPs and midwives as well, and look at how do we attract staff into the organisation at the beginning of their careers and keep them here for a lifelong career that will be varied and interesting.
So that's important to you, Fiona.
Yes, very important to me. That's part of the income.
So I think it's really helpful for Cam to talk about that, because I've heard you talk about it, Fiona, already in the short time you've been here, and I think we are getting to a point whereby we either need to commit to that or not, because we can't say to people who want to progress, just keep waiting. So I think we have to make it. We have to decide how we're going to do that over the next couple of months. It's not for today, but I think it is on the basis of what you said. I think we need to take that. We need to come back as an executive to the board and say either yes, we're going to do this, or no, and be honest about it. I think we should bring that back as an action.
Feels so positive that you're
Yeah,
chief nurse and you're behind it, Fiona. I think that's something.
it's nationally recognised part of the structure of a nursing workforce that it should include healthcare support workers, nursing associates, registered nurses, to make the workforce affordable and able to work in a qualitative way for our patients. That's what it's all about. It's the right people in the right place and the right roles delivering care.
Hey, did you? Yeah, I thought that got the speaker stand. Where's the hand? You know.
And I just to echo some of my colleagues, it's really, really great to hear your stories. I've got 2 questions. I'm going to ask them both. I think one for you. So very, very sad to hear of some of the challenges you face, especially the first question is around What can we do to support them more? And the second question really relates to patient experience, and I think when you mentioned the little things and how they really meant a lot to people, and just listening. So if you had more time to do something, what would it be? What do you think would drive the best experience for those?
How we can support everyone, how we can support us in our cardiology work, because this is what I'm doing. I'm not taking longer. I just came here for half a year in UK, Hong Kong. So this is my first UK job, and actually I was a nurse in Hong Kong, so I experienced like that a lot. But when I came here, this culture and the practice sometimes they make me very touching, because the family very grateful for our work, and the patient as well. And sometimes our trainer Sharon, she supported me a lot, because our work is quite special. You can see one patient came in our work. She looks bright. She is mobilized, but the next day she may just die on the head. I'm very sick. Local cardiology. I mean, sometimes it's quite sad. Even I was in the problem, it's emotion.
Can I say I love I
Sorry.
and I love to hear that you care so much. I think it's great.
I'm not sure. All of them trained at today. And sure, I'm very support, because she always come to work with me, visit me, and she really up my emotion. And I told I learned about from my patient. Being very strong, very strong. It's totally different from my previous experience. So I'm so glad hospital have support us, and they will get the trainer and to visit us. So if it is available, I hope different. I hope we all can raise or can promote a ambassador and can help can care about the emotion when they're facing the new they just can't for a new one. You practice on new experience in making hospital, and you have give some psychological support. I think it's very beneficial.
Yes, I think it's not, and I think it might be good to answer your first question. You work on gastro next, so you have a lot of patients that might be detoxing from alcohol, might not be behaving as they normally would. And what would you think would be more supportive?
So it's difficult to answer the question on everyone's behalf of the trust, because every part of the trust is different, every ward is different. But somewhere like, as Alex just said, somewhere like my ward's on a gastro, we get a lot of detox patients. So we get a lot of patients who are basically on a one-to-one. So they have to have somebody with them at all times. We have a continuous struggle of the trust not being able to find someone to stay with that patient, and then it's then relying on HCA to then sit with this patient who is on a detox, who's violent. We have to deal with that, and I'm then trying to deal with my 7-8 other patients, as well as trying to make sure that this patient doesn't come to harm, because his interest is still my interests. So you can't forget that. I think it's just the staffing, but again, that's an issue everywhere, unfortunately. But just more support for the wards that need it when they need it. And I explained to Alex before, the matrons should come on the ward and look physically at the staffing. Now it's all done online. So last week I got moved to a member of my staff got moved to another ward. This left me with a member of staff who's 7 months pregnant, I then feel as if I have a duty to not only support her now, but support 21 patients and make sure she's not overdoing it. If it went back to how it was and, you know, people were physically looking at the staff, I think they'd think differently. So actually, we can't move this person because that's going to leave Cam with another member of staff who's 7 months pregnant. It's changed, I understand, but sometimes it's nice to see a face on ward. They physically look at the staff and go,
And I think you made a really good point now around the patients that might be violent or aggressive. Is these patients are having some kind of acute delirium, some kind of acute mental health. So naturally, we've got healthcare support workers who aren't necessarily the best prepared people to support those patients with their mental well-being when we're ultimately there treating a physical symptom as well. And I think we talked about that before, didn't we?
I would like to add this. Patient with confusion and all that are really a big problem because you actually know that they're confused. What they're doing is because they're confused. And those that are fully aware, as they abuse that, doesn't really make sense to me. Like, I'm here to take care of you. Why are you responding to me like this? So maybe remind them when they get into the hospital that you're here to be treated. You're not here to abuse workers. I don't know, maybe posters around because I want 20 more 23 posters around because one of our nurses was by the family actually, not just the patient, it's also the family. So maybe find a way to remind them that when they get here, they're here to get help and not to treat.
Just a couple of things. First of all, I just want to say, aren't they amazing? Every time I speak to them, I spoke to them as part of pre-meet and they choked me up and they do it again today. I'm so proud of them as a workforce and they represent hundreds of other healthcare support workers out there with the same passion. I just want to respond to a couple of bits to give the board some assurance that we are aware of the challenges. They know some of the things that we're planning to do. Thank you, Winnie, for talking so very well about the wellbeing support that we provide for our healthcare support workers, and I will take that away. I do want to set up a forum. I know you meet with Joe, but I want to set up a specific forum with healthcare support workers to talk about care, to talk about challenges of care, and we'll start thinking about how we can support you through that with your wellbeing. So I will definitely take that away and quite quickly to come into place. I also just wanted to touch on the challenges that we face around patients when they require enhanced care. So this is the one-to-one provision of care. The tool that we use was recently upgraded. There's been a national recognition that enhanced care is providing a strain to our staff, not just through emotional and wellbeing and the physical challenges of caring for people with challenging behaviours, but also financially that provision. And the tool has been updated. We've just run our first cohort of looking at what those challenges are and what the staffing requirement would be to provide a more consistent workforce to provide it. There are lots of options for us to look at around how we do that. We do have to run that tool twice before we can sit and say, actually it's starting to give us more evidence base, but we have that early feedback and I'll be bringing that through to board as part of our safe staffing report, 6 months report, which we're just working up now. So just to give some assurance around that and to give you some assurance that we do understand that challenge and we're trying to look at a very consistent response that we'll be able to embed across the trust. And it has shown us areas where there is increased area. And can I also say, because Cameron's been very shy, but as part of being polite, when he came to see me yesterday, in his pocket, he had a letter that was delivered from a lady, a relative whose father had died. The father wasn't on the ward, but she took the time to write a letter to Cameron to say about the impact that he has had on his father, on her father, who had come in and out of that ward all the time. She took the time to write that. And that stayed with me last night when I went home to think about actually the impact that you had on her and her father is immense. And I think it's just a shining example. They'll all have stories like that. It's just a real shining example of what essential works.
So I can only say a huge thing. We could talk all day probably, I think, with you guys. And I know everyone can spend some time on wards with people, so hopefully we'll get to meet some of you again out there and you can show us on the ground what you're doing. But I'd just like to say thank you. But thank you to all of you for coming and talking, because I think you've really shared your passion, expertise and commitment to what you do. And it's been a fantastic conversation for us to have. So thank you very, very much.
Thank you.
Thank you. You're allowed back now, John. We shop it away well. Yes, you seem to be on now, so you should be on. So that's fantastic to hear. I think great. It's great. So here from
Carriage to number 10.
yeah. Excellent. So that's, I think, a really good conversation to have. It's a hugely important part of our workforce. We don't speak to them often enough, I think. I have to say, I watched on Ward 2 a few weeks back. I was watching the healthcare element. I was watching the healthcare assistants doing the lunch. And yeah, they were just a slick team doing, doing what they were doing completely by themselves and making sure patients were getting what they needed to get in the right order. So yeah, very impressive. Okay, so we'll move on to, I think the next part of the agenda. So we'll move on to the minutes of the last meeting. Are there any comments or amendments, changes to the minutes of the last meeting that anybody would want to make? No, so we'll take those as given. Thank you very much, everybody. And then there were just 2 points on the action log. One of them was already. Oh, yes. So the risk management piece will come back in. So, previous conversation. And then we were talking about the price selection regime. I don't know if you want to comment on that.
It was back in, the action is
December.
December.
Yeah, that's right.
Yeah.
So happy about that. Any other comments or any actions we thought we were missing off the log? Excellent. Thank you very much. So I will move on to the chair's report. Got lots to go through today. I just thought I'd make an overall comment on the amount of engagement activity that both Louis, Staffia and Kenny are working on this. There's always lots of things going on out there in the wider community and indeed in our trust. And I thought one of the things I'm going to think about over the next couple of months is how we bring some of that up in here in detail without just sort of kind of reading through a list of all the things that are happening. But there's so much engagement going on. As part of that, I visited King's Community with Andy Forbes, Governor, where he's the pastor in Wolverton, and a really impressive operation doing a food bank. They run a quarter of the food bank out of King's Community in Wolverton. They run a quarter of Milton Keynes food bank out through there, and they also do lots of different innovative things, top-ups, hygiene bags for people that really want to get things that they can use to keep their house in the appropriate hygienic level. And they get something like 1,500 people they've got signed up to their community work. Interestingly, going there, people want to meet people from the hospital, so they can ask questions and get help with what they have travelling through. So I think these are the portals we can use to put our message out about what we're doing here as a trust. And I think we'll build on that kind of idea of how we work with the community, perhaps in some of these settings over the coming months, and as we continue to build strategy in the way that we're working with the community. We had a lovely armistice remembrance service on site on Monday. Many of us here attended. It just felt very nice. It's a very short, simple service led by the team, but I think really important to mark that day. Team on site. And then just to say that I went to an East of England meeting on last Friday, where we spent time in the morning talking about the 10-year plan and working in discussion with the team who are doing that nationally. And we divided up and took different topics on analog to digital, sickness to prevention, and as across both the setting, we put input into how that might develop through. It's obviously part of the national conversation that is taking place with both members of the public staff and everybody that can be included in that conversation. Actually, I felt it was a good conversation we had with some robust challenge about how we focus on few things to get them delivered rather than trying to eat off an enormous agenda, which won't happen obviously in a short period of time. And then we spent the afternoon. Chris Whittypen joined us, which was an excellent session talking about the health of the population and about how we make sure we've got equitable health delivery for people in deprived and socio-economically deprived areas, but also really what his focus is on in terms of prevention and how that plays through everything we're doing in terms of working with people in the community, working with people from a young age, and in terms of prevention or in the case of dementia, delay, and how that builds in across everything we do here as a trust, working out with partners in the ICB. And I think there's again more there we can develop and share through as we build kind of our future plan. It was a very good session. So lots going on, and I think that's all we've got from me. Joe, I'll hand over to you for the chief executive.
Thank you, Chair. Lots has been going on since the last time we had a public board. So we had our annual members meeting back in October. It feels like a lifetime ago now. That was combined with our long service awards, which was a fantastic event in the centre of Milton Keynes. Excuse me. We've had Black History Month, where the trust has held a number of events internally, but also has joined with the ICB and region to run some combined events, and that was very successful, supported by the BAME network. So big thank you to them. We've had the National Pay Review Body come and visit us. They wanted to come and talk to some organisations prior to going through the process of the National Pay Review. And some of you may know I represent the NHS Confed on that, so they came to Milton Keynes. And I think it's fair to say they were delighted with the groups of staff that they met on one point. Second point, which I think was really interesting, was that they referenced the fact that a lot of the issues that the teams here talked about were national issues rather than local issues. They said on the other visits they've had, members of staff have talked about things like paying for car parking and tea and coffee and such like. So it was very noticeable. The team here talked about the sort of national issues rather than things that their local organisation could get right. So that was nice to hear. You mentioned the Remembrance Service. It was also March Faith Week last week. And big thank you to Sarah Crane and the chaplaincy team for all the work that they did to publicise that. And then I want to just finish, if I may, by talking a little bit about some of the performance things that have been going on. Obviously, our Secretary of State was very vocal yesterday about how he would take to task various senior managers for the performance of their organisation. I'll comment on cultural change that might bring in the NHS, but I will comment on the performance of our own organisation. So delighted since we last met that the CQC have rated our emergency department as green across the board. That's an improvement in a couple of areas, and I think again is an indication of the focus on quality that this organisation places. So delighted with that. I think it's also important to note that from a performance perspective, emergency care and our performance against the 4-hour target, we are in the top half of the country. We are getting better when you look back over the summer to where we are now. That's in no small efforts from Faye and the team, and you'll talk a little bit more about that when we come into the performance bit, but I think it's important to note that. There's been a lot of noise and concern, quite rightly, about elective waiting times for our organisation. We were highlighted a couple of months back about being the worst nationally for performance against the 18-week target. That performance has subsequently improved and we're no longer the worst. There is some way to go, and again, Helen will talk about that in her performance report. But just for this board's awareness, I think it's useful to know that half of the patients that were seen in September were seen within 9 weeks. So yes, we've got some long waiters, absolutely, that we need to clear. And you will have heard me talk about the impact of getting significantly more cancer and urgent referrals coming through. And so what we've got is a large cohort of patients that are being treated very quickly and too many patients who are waiting too long. And so we have to combine our efforts to make sure that we reduce the overall waiting time. I think the other thing to say is we're halfway through our staff survey. The board will recall that we were #1 in the country for staff wanting to come to work and the morale aspects of that. And we were in top 10% on the other metrics. I know that Catherine and the team are doing a huge amount of work to encourage people to complete their staff surveys. And I think that will again hopefully show that all of the efforts that we put into health and wellbeing agendas here does get reflected in our survey responses. I think the other final thing for me to say is again, Jonathan will talk about finances in more detail in his report. But it's important for the board to note that we were one of a few trusts that submitted a break-even plan at the start of this year. We are very close now to delivering the CIP programme. All of the pressures that we have around things like extra work and premium costs is clearly putting pressure on that position. But the point of going through CQC, emergency elective, and our performance is it's a very complex task to judge an organisation's performance in the NHS. And when you look at all of the different metrics that we assess ourselves against, yes, of course, there are areas that we can improve on, and there are areas that we are doing well and we are recognised as doing well on. So I just want to make sure the board is precise on all of those. I'll pause and take any questions.
Quick one on, thank you, Joe. You mentioned CQC rated green. What is green?
Green for good. Yeah,
Good.
There are four categories. I believe there are still 4, although outstanding is rarer than entity.
Yeah.
There are 4 categories: outstanding, good, requires improvement, and inadequate. We are good across the whole of the organisation. ED requires improvement in well-led and in safety, and they are, in the previous inspection, they're now green, good across all 5 domains.
So I'd like to add my congratulations to the team for that. Any other questions? I think I'll just comment, Joe, as well, that on Friday we talked about the money and we talked about the challenges of the money, but the real challenge being the waiting lists. And I think you're right, it's that complexity of what's going to get the focus. What is it we're really trying to do as a trust, and where are we going to come out, not necessarily today, 2 months' time, but 6 months' time, as we're working through some of those challenges. So I think it's about keeping that balanced oversight, isn't it, of all the factors that we are working through. And I think that was acknowledged on Friday, that it's not per se about a single financial target on a single day, but I think sometimes it's getting that perspective, isn't it, held in Jonathan's model. So,
and if I may add to that, that the complexity of the environment that Milton Keynes operates in is different from vast swathes of the country. So to have upwards of an 80% increase in cancer referrals since pre-COVID, and to not expect that to have an impact on overall waiting times would be naive. And the reality is that that's what we've had here, which is very different to other parts of the country. And we are clear as an organisation that we treat patients in that clinical priority order. And therefore it has had an impact. It's an impact that we are absolutely now playing catch up on to make sure it doesn't continue to hit our patients with longer waits. But it is challenging.
Joe, from my perspective, the finance feels that one of the challenges that we've got on the finance side is the consequence of the rules changing on us, particularly around your IT curve and how we're paid for it, which feels a little bit like beyond our control. So I just want to set that in context when we talk about the challenging environment. my perspective, we're doing an awful lot, but it feels to me like if the rules change, then that might be an inappropriate comment to make, but it's thinking to us, from my perspective, in the record, that part of the challenges we've got because it's those are targets we've got.
I think we should talk about.
Is that
if I take the national picture, quite rightly, the national team are looking to standardise how organisations capture, record, and report and get paid for activity. I think we have absolutely been caught by one of those changes, and I don't mean caught out, I mean caught, where we have agreed something locally, and over time that has meant that we're an outlier. So yes, it has a direct financial impact on our organisation, and I think the region are looking to support us as best that they can in trying to smooth out that financial impact, and I'm sure we benefit with some other changes as well. So yes, this one is a particularly big one, and we're still working with the regional team and national team to try and make sure that we don't get disproportionately disadvantaged.
Joey, any comment on the ICB update, or it's just attached?
Excuse me, it's there for information. I will take any question.
There are no questions on that, then I think we will move on to patient safety. And the first item is the patient safety update. Am I looking at your summary for that? Thank you.
I'll take that. Thank you very much. So, patient safety, the paper looks at patient safety activity in the last few months, so September to October this year. However, I think it's important to say that we changed our way of review of incidents. First May, so 6 months ago, we introduced PISA, Patient Safety Incident Response Framework, and we're using that for the last 6 months, as I say. And that entails a daily multidisciplinary triage of all the incidents and the weekly local patient safety huddle, which occurs in clinical specialties. And then all that information is put together to create or to understand if there are any themes that are emerging. Some of the things have been reported in this statement. So things that might include patient calls, tissue damage, medicines management issues, and the like. The expectations that an annual report will be produced, so that'll be in 6 months' time. And now at the 6 months hiatus, we're using this opportunity to do a stock take of the whole process and to understand how we iterated and improve it further. The principles of the PISA include system-focused approach, focusing on continuous learning and improvement, promoting supportive and psychologically safe teamwork, enabling and empowering speaking up by all. And all of those are absolutely key to try and bring out as many conversations, also conversations around incidents, as we can in different parts of the trust. And then the other aspect that I think is important to draw out in the paper is our reporting system is called RADAR, our incident review system is PISA, as I described. And it's very important that they link together and link together better. So in that vein, we've created visual dashboards and PISA dashboards. So dashboards that link RADAR and PISA and give us much better visibility and allow us to dig down much quicker into incidents and the learning from incidents. Just before I finish, it's important to also say that we've increased our number of incidents reporting over the last several months, and that's really good, suggesting that we're better on the trajectory of a positive reporting, having a positive reporting culture. And then the final thing to say is, how do we bring that learning to the rest of the organisation? That's also really critically important. And we're doing that in a multitude of ways. So we're learning in a multidisciplinary meeting every day. There's learning in the weekly clinical specialty meeting that I said already, but also we're creating or writing patient safety newsletters on a monthly basis. We're looking at case studies which we're disseminating to the whole population of the hospital, and we're bringing together learning events. So in the last 6 months, there have been up to 200 learning events, again multidisciplinary, where specific incidents are discussed, and the learning from that is disseminated. And then in our monthly plenary afternoons, we're using those, which are trust-wide, like governance afternoons. We're using those to, again, disseminate information that we learn from some of these incidents, so that we're not working in silos, we're trying to work across the organization.
I'm just going to ask you one question before I go down. I always worry when I see something that says, we'll be in transition, therefore the data is transitioning. I always worry that means we might be missing something or not understanding. How confident are you that this gives us a good picture even today?
So the radar system still is there to report, so that's not transitioned at all. So we're using the radar system as we have done for so many years. We're increasing our number of incidents that are being reported, as I said. So our expectation is that we're now reporting more than we were reporting before, and that's giving us more assurance about unearthing incidents or themes that might be coming across the trust. So we're very confident. Having said that, I think it's important to say that we are also at 6 months taking a stock check on the process. We think there are ways we can improve it, like dashboards, which we started just this month, and we'll see how that plays out. And there are other improvements also that I think we can make over the next 6 months or so to try and get our incident reporting even more robust.
So, James, I think research is a great initiative. You talked about it, and support it. I would like to understand a little bit more what the implications of the overdue workflows are, whether they're point to resourcing issues. That in itself could look back on how the whole procedure has been received if we're not escalating, triaging, and moving forward. So I just what needs to be doing, and what are your thoughts on that, and what we can do to expedite that process.
So I think it's a really good question. We have invested a lot in patient safety champions, and the patient safety team is robust and growing. I think you are right. There are overdue incidents that have been overdue incidents even before PISA, and we will say that. There are no national guidelines on the timescales within which we do the investigations. However, we've got internal guidelines that are relatively tight. So to try and turn around these investigations, we're monitoring the number of overdue investigations all the time. And clearly, if there are resource limitations, if that number continues to grow, we'll introduce more resource into that team. But I think it's important to say we have done an awful lot of resource or putting in resource into patient safety. This is a new system that we're working through. As I say, if required iteration, we've created our own internal guidelines for timescales, and we're trying to work towards them. And I think we'll have to see in the next 6 months or so whether those guidelines are appropriate or whether we need to extend that timescale even further, or even, as you suggest, sometimes
we start getting to the effect, so it becomes so great.
Indeed.
Yeah, one different point. I don't know.
Yeah, no, I just wanted to sort of add to that around the triage piece that Hannah referenced, that actually from a CNO perspective, I'm assured that they are looking at and pulling out the right cases that need intensive focus very quickly. And that when I look at some of those longer waiting ones, I feel quite comfortable where we are on that trajectory. Often they're being pulled into action plans for a workflow across the ward. So there may be a number of, for example, pressure ulcers or falls, and we're putting it into a falls pressure ulcer action plan for the ward related to a number of similar incidents. So I think that the new process, and particularly that triage point, is really key for us to make sure that the right incidents get focused at the right level.
So I can just repeat what you said to make sure I understand it, because I'm quite keen on themes rather than dealing with it. So what you're saying is making sure we pick an appropriate the appropriate types of incidents to pull out so that we identify themes that we can focus on and take action.
Yeah, so a key part of the PISA process coming in was to prevent a number of a ward, for example, having 10 different action plans running around the same thing with 10 different examples. And what PISA does is it pulls in one action plan and you link it to all those different instances and drive that forward.
That's very helpful. Thank you.
And I think the thing to add to that is that's trust-wide rather than ward.
Yeah.
Yeah. So the theme go across the trust and not the ward.
Yeah, I think that makes a lot of sense. Thank you.
I just wanted to reference violence and aggression because it was picked up by the HCA team earlier on, and it is a theme that's coming through reporting. We've done a lot of work to encourage reporting of incidents where staff are abused either physically or verbally. We've got a large quality improvement program, and we're doing lots of work in this space. I don't want people to think there is not a lot of work happening behind the scenes. We focus very much on training, and particularly in places like ED. what we are looking to do at the moment is to try and find the best interventions we can make with our most complex patient group, and those are patients who lack capacity in some ways. So maybe have dementia, maybe are detoxing, as Cameron mentioned earlier, because we are caught in a between, we can't discharge these patients. It wouldn't be safe to do so. Sometimes they're under a deprivation of liberties safeguard, so we can't. And we're looking at how we manage that most appropriately and lawfully. It's really challenging to know what the best interventions are, other than staffing might not necessarily be something, maybe, but it may just be putting somebody else in to be used in some way. So we're working with the national team. We're looking at learning from other areas. We're looking at what we can do around particular patients. We're using some examples of particularly complex cases where we're testing things out legally. It's a very, very large, when we talk about violence and aggression, it's everything from, somebody who comes in and is unpleasant at the front door of A&E with full capacity. That's the easiest situation for us to deal with, to the much more complex patients who have been with us for several months, who are waiting a placement, so I think it's a huge sort of category of incidents. There is a large amount of work happening in that space, but we do respond to individual members of staff to give them support and care, and teams as well when there has been a particularly unpleasant incident. So there's a lot of work happening, and we'll bring it back through health and safety reports as well. Thank you, Kate.
Thank you very much, Annie, for that report. I think you're taking the next report on mortality, please. Thank you.
Yes, Angela, thank you very much. So we look at mortality in quantitative and qualitative ways. In terms of the quantitative evidence, it demonstrates that the risk-adjusted mortality in MKUH is as expected when compared to our peers, so there are no major outlying areas of concerns. I think it does need to be highlighted because it's in the report that the figures are particularly volatile at the moment, and that's mainly due to the changes in coding that I think Mark already alluded to. And I think we are going to have a national emergency care data set which will come out in due course, and that will lead to much more standardization of the denominator of these equations, such that we then have a much more standardized approach to report quantitative evidence. In terms of the qualitative evidence, we use the medical examining system and have done for many years now. I'm sure you're all aware of that. And then through that, we create structured judgment reviews on specific cases that we think about merit. And obviously, there's the statutory correlative system on top of all of that, which reviews selected hospital beds and then provides an added layer of assurance. And then we create, through the mortality review group, a report that goes through to patient safety board, and then that goes through to the trust executive committee. So hopefully that creates a level of assurance in different layers. I think it's important to say that as I've already mentioned, that we have some volatility in the quantitative numbers. In terms of the medical examiners reviews, we were looking at all the hospital deaths. We're now looking at the hospital deaths, the community deaths, and the deaths from the hospices as well. So that allows us a much more integrated view of patient pathways and what causes there might be to patient death and how we might be able to intervene early. However, I suppose in conclusion, I would say there is no signal of us being an outlier in terms of our quantitative or qualitative data. And then the last thing I would say is in terms of sepsis, there is an increased number of structured judgment reviews that we do for patients that we think might have sepsis or sepsis-related deaths. And that's a good thing, so that we scrutinise all deaths where sepsis might be a contributor. And also that shows that there is no signal to suggest that we're an outlier in terms of sepsis-related deaths.
Thank you. The structured judgment reviews that are undertaken by medical examiners, I may have made the first mistake. They are our medical examiners.
Yes.
Okay. They undertake structured judgment reviews of all coronial inquests, don't they?
Yes.
So do we know whether there is any difference or any divergence being shown from the structured judgment reviews that are being undertaken and coronial verdicts that are coming through? I.e., have we had sufficient time to see whether there is a coronial review that is saying this patient died through a harm issue associated with the organisation, and the structured judgment review is saying nothing to see here, everything fine. Do we know that yet or not?
So thank you for explaining. We didn't understand the question initially. So as far as I'm aware, no, there is no difference. What has happened in the recording reviews is that they've highlighted specific things that they would like us to go back at and look in more detail. And then we created further work around the structured judgment reviews to increase the scrutiny in certain cases. But not that I'm aware of a difference in opinion on the outcome.
Thank you.
I think mine is more a comment really, and perhaps for policy and risk committee. I think Shimmy shows us what it shows us, and rolling we can see there's a sort of upward position. And we'll assure ourselves around not being an outlier. I think it would be helpful for the quality committee to have a discussion on some of the things I think you talked about, which sit underneath our assurance, so that the quality committee could then assure the board that it has looked at this in more depth. Lovely, thank you very much. Fiona, I think we're moving on to yourself under the patient experience heading, and we have the maternity assurance update.
Thank you, Chair. So this is a verbal item. The notes haven't been through due governance yet. The timing of the maternity assurance group in this meeting is a little close for that. So the last assurance group, we held that on the 24th of October. It had good multidisciplinary team attendance. Just items for the board to note of things that were reviewed. So we welcomed our maternity and neonatal voices partnership co-chair, that's the MAVP, if people are hearing that acronym, Roxanne Clark. She confirmed that work plan that they've said has now been signed off by the local maternity system and the ICB. There are things within that that align across the CQC work plan, and there are areas that have now been identified through those two plans, pulled into quality improvement projects that are now registered on radar and will be governed and managed through clinical service unit and assurance through MAG. So we'll be able to bring back any improvement and changes on the back of those two pieces of work and review that have occurred. I'd also like to note that on review of the maternity workforce plan and our imminent newly registered midwifery recruitment, the maternity risk for midwifery staffing was reduced from a 15 to a 10. We have much greater staffing in that, and I'll touch on that in the next report that I present. But that's a really positive thing for us. Let's reverse rate plus we're able to demonstrate robust maternity staffing. We also looked at, as part of our corporate governance, we received a quarterly report on perinatal mortality. And there were 4 cases that were reviewed, and all close cases were closed, apart from 2, which are inquest. These are really sad and difficult cases for staff to deal with. However, it is worth noting that there was no care concerns highlighted in any of those reviews for military unit. The group continues to monitor the maternity incentive scheme delivery action plan. And it was noted this time that due to recent medical staff changes, there's a risk of compliance that we picked up around achieving the 90% compliance rate on mandatory training. But we have some robust plans that are going in place, and we'll monitor that through that group. And we'll be very assured that that will be turned around to improve upon and achieve. We also took an update on our preterm optimisation quality project that is underway, which relates to care elements for babies that are born prematurely. So our Prem7 audit data has been reviewed through the group, and this quality improvement project has come about as a result of that. So what we're looking at are, for our population, single births that are over 27 weeks and multiple births that are over 28 weeks. Let me get this one. Should be born in our unit. So if they're under that rate, they should be born at a specialist centre. When we reviewed our data, we had a number of cases that had gone elsewhere, and it's really important. Obviously, birth isn't something that we can plan or stop, but it's really important that we review the pre-care that occurs for those cases to ensure that there is nothing in that pre-care that influences the outcome. So there's a quality improvement programme going on, and that we received an update on. And then just to update on the CQC, there are no updates on the outcome of the current CQC maternity inspection. We're still waiting to hear news from them. So that's the maternity assurance week update.
Would you just remind the board when the CQC visit took place?
It was in July.
Questions, Gary?
Some questions for me. I read the report, and it's my lack of knowledge and experience around birth rate plus and
Oh, I
stuff.
think that's the next report, but yeah, carry on.
Oh, sorry.
I'm happy
Apologies,
to.
I'm jumping in. My question was really simple, having read through the document. I was trying to get a sense of whether we feel our staffing is where it should be.
Yeah,
Let's come to that.
Just kind
Yeah.
of.
To that report. Is there
I think
anything
I'm gonna
else?
answer that.
Yes, yeah, I'm sure we need it there anyway in terms of. Fiona, I only have one question, which is there's a huge amount of information, isn't there, out of MAG. MAG covers a lot of,
yes.
and I think we've had this discussion a year ago abroad about what assures the board. Do you think we're bringing the right things here in this report to assure the board?
It's interesting because I looked at it, and obviously I've referenced that it's a verbal report based on the last one. I guess we could pull the notes out and send the notes or send a précis of the notes, but we would be, it's a monthly meeting, the board meets every other month, so we could bring along, but we would miss stuff. But it may be worth just looking through, but from my perspective, I feel the information that I've pulled towards your attention this time is correct. I guess I'm acutely aware it's a verbal, and having something in writing is possibly more assuring for the board to be able to develop.
I shall leave that in your hands, I think. Decide what you think is the best route through, and I think again, as part of that policy committee discussion, we can talk about how we feel assured. Joe, your face looks like you want to say something.
I do. I do. I'm just thinking how best to say it. I suppose I reference back to the performance matters that I raised under my report, which is that there is nothing flagging at the moment within maternity that actually suggests it should have a separate report to board, other than a bureaucratic architecture of board reporting that's imposed upon us.
Yeah, and I think having the maternity neonatal voices partnership at the meeting, so we have external, it's chaired by a non-exec. So we have that oversight. So I think with the verbal coming here, it probably is acceptable that we've got the right scrutiny.
We'll move on to the workplace report.
Thank you. Again, I'm going to take the paper as read and just draw your attention to a couple of points. The first point is around that we're maintaining a focus on safe staff and ensuring that we maintain our MIS Year 6 standards. So we're going to repeat our birth rate plus assessment. So birth rate plus looks at the number of births we have and whether we've got the right staff for the number of births that we have. And it's a flexible thing that adjusts every day, but we also have a longer term plan that we look at. So just to assure the board that in order to keep on top of our MIS, so maternity incentive scheme reporting, we're going to do that assessment again. The paper does touch on a discrepancy around the data on PWR, and I'd just like to assure the board that we have now ironed out that discrepancy, and we're much more comfortable around what is this an HR thing.
Well, yeah, does PWR?
You're going to ask for that. I was going to ask Catherine beforehand.
We'll find out.
It's our workforce report. I just can't remember what the P stands for.
Patients.
Sorry.
Sorry.
Oh, that's sorry. Thanks, Joe. So work's ongoing just to align that. So it's a report that comes out from the central HR team around our vacancy and around what we actually have in post in regards to ESR. So our current position for maternity vacancies is now less than 1%. It's 0.45%. That's including some newly qualified midwives who are arriving in the trust as we speak. And they will go through a period of supervisory practice and then we'll be out in our numbers. So a really positive position for maternity, which is why we've been able to reduce that vacancy down to 10. It's also important to note that following a recent roster build, the data does show a decrease in fill rates. However, because we've changed the way we're working and the way we respond to birth rate plus, the actual number of midwives in each area has improved. And it's a period of short-term sickness that's just influenced that dip. But actually, with regards to meeting our birth rate plus requirement that every birth has a midwife, we are achieving that and we are maintaining that standard on our local board. So I think in answer to your question, yes, largely is right.
I tell you what I was thinking of. It ties in with Joe's point, which is that it will when we look at the exact summary, it's useful to know whether we've got a problem or not.
Yeah.
You know, and so there's words here, but I'm not any wiser when I finish reading through them. And I kind of came to the conclusion we didn't.
Yeah, sorry, I think it's right in the back of the report. It says that we do achieve our birth rate. So we'll make sure it's in the very
green, amber, red, you know, worried, don't worry, we're concerned.
So-
This
yeah. So I would say our current position from a total perspective is not to worry
Yeah.
that we are fully recruited with 4 or 5% of a vacancy.
Other than, of course, within our physical estate, which is why we need weekends. Never miss an opportunity on
You've got your list of stuff.
I probably, mine's a grumble, because I'm talking, that's just what you want really, Fiona, isn't it? I think it's on page, what page is it? Page numbers. I'm looking at 4.1. Provider workforce returns review, somewhere in there. We just talk about her not having recorded the correct number of midwives and not reflecting.
That's the PWR piece, yeah.
Yeah. We just, you must know, I mean, I've always got a thing about this, about when we say we don't know what staffing we've got. We don't say here, my previous organisation, we say we don't know how many people we've got in a unit.
So my understanding of the discrepancy is it was around reporting timeframes. So what goes out from the trust and goes to the LMS will be reported on, for example, August. And then Elaine will go and we'll be talking at a more localised meeting and be saying, oh, our vacancy rate is now 2. And they say, well, it's here. So what we're trying to do is work together to align that. Actually, when we take data out of the organisation, we're making sure that we're all talking about the same page. What's in the papers is relevant for reference. And that's the piece of work we're working through with data.
Not really having a grumble at all, but
That's fine.
And delighted to see that provider workforce return is the PWR.
Thank you.
Provider workforce return.
Right. Any other questions for Fiona? Before she can breathe. Feeling like everyone's looking for the.
Thank you.
Thank you very much. Thank you. Lovely. So we move on to performance. We're kind of doing okay for time, I think. So Faye, you starting with this? Faye and Helen got mentioned, and I wasn't sure whether it's both of you or one of you. Faye.
Yeah. So just 3 areas to cover on my. Okay. So the first, and Jo talked earlier about urgent and emergency care. September over the last few months has been quite busy, but what we have been seeing is some days we are seeing over 350 attendances, which is quite a lot for accident and emergency to deal with in a day. Our 4-hour performance is 73%, as Jo alluded to earlier. National average is around 74.2%, and we are sitting up there in the quartile for that performance, which is good. The areas that we've been focusing on in urgent care is around what can we do to maintain that flow through the organisation, because when we have 350 attendances, the department gets pretty chopper. So we need to make sure we've got flow going out through the back door. So one of the areas we've been focusing on is our no criteria to reside, and you'll see within the report. At the time, we had up to 120, and indeed peaked, I think, at the beginning of October to around 150 patients with no criteria to reside. So these are patients that don't need to be in our hospital. I'm pleased to say some of the work that teams have been doing, as of today, that sits at 83 patients with no criteria to reside. And the majority of those patients will be patients that need to go out in some degree of pathway, complex pathway. We've also been focusing on length of stay, super stranded being one indicator of that. And again, we've seen a decrease in that number from 122 to 91. So we're absolutely moving in the right direction. And that's been involving partners across the system to help in mobilising and getting better traction on some of our patients, the complicated ones that Kate alluded to, and is quite helping us out with some of that from a legal perspective. So we'll remain focused on those areas. Diagnostic performance is the next area. Again, we've seen incremental improvements in that performance, but I guess we're not really going at the pace we need to. That said, we have a plan with each of the modalities, so MRI, CT, etc. And I'm pleased to say that over the forthcoming weeks, we've got additional activity going through our community diagnostic centres, which will
will mean we will see a much better pace behind our improvement trajectories over the forthcoming weeks and months. In addition to that, this week we heard that we had been allocated nearly £600,000 towards cancer performance, which will enable us to bring on our second CT on site, which will also help our diagnostic performance, but importantly our cancer performance. At the beginning of September, in terms of cancer, we had nearly 170 patients over 62 days. Again, there's been an awful lot of focus and work going on with cancer. As of yesterday, that number is now at 142 patients over that 62 days. Clearly, that's not where we want to be, but we are absolutely moving in the right direction. And with the extra CT coming on board means we will be able to diagnose our patients much, much earlier on in their journey, which means they should be able to get their treatment a lot quicker. So lots going on in that space.
Okay. Do we want to take questions? If I think that might be a good idea to do it that way. If anyone's got any questions.
Did we miss the patient experience?
Oh, I'm sorry. Kate did say earlier that we were going to take that out because we've had that paper and we're going to come back with
your report and a plan to go to quality committee and it'll come up again.
So sorry, just interested in what's driving the increase in patients not meeting criteria to design.
I mean, I think it's fair to say it kind of goes up and down. So my focus has been very much on patients that are on what we call pathway zero. So patients like us that could leave the hospital today under our own steam. That's our focus, and we've really been very much focusing on making sure that patients have a step in their journey to get them out of the hospital as quickly as possible when they don't need to be here. And I think there have been areas that we've been able to improve on. But additionally to that, at the time, we had a significant number of patients that were waiting to go out on the pathway. So patients waiting to go into residential homes or rehabilitation or to go back into their homes. But we've been working really closely with our system partners. This week, just on Monday, we had 17 patients go out. When I first came into post, we were taking 7 or 8 patients out on that complex pathway, which is not what you need. We need to be into those double digits to be able to drive that number down. So I guess the challenge is how do we keep that focus and how do we keep that number down as low as possible. I think it's an ongoing discussion and ongoing kind of conversations with our partners almost on a daily basis. So we've been running fortnightly complex. We used to call them main events, but actually it's more like a complex focus going through every single patient that we have in the organisation wanting to go out with the pathway. So and we're picking up lots of themes that we can focus on those areas to try and get people out.
A couple of things. One is it is a really significant improvement to go from 150 people. I interestingly call them people because they're not patients actually. There are 150 people in our beds that don't need to be here, down to 83. And so I think that's a huge achievement. And we know that we still have effectively at least 3 full wards of individuals who do not require physical support from an acute hospital service. So there'll be a continued focus on that. I think the second point I wanted to make was just around the cancer piece, which is that for those who are unaware, when you treat a patient on the cancer pathway, it gets counted as a breach and impacts on the target when the patient is actually treated and you finally sort of close off that treatment. So what we've been doing over the last couple of months and what we'll continue to do over the next couple of months is treat the backlog of patients that have been waiting for cancer. That will, of course, by the very nature of how the calculation is made, take our cancer performance down. And I think it's important that the board are aware of that, know that it is a planned position rather than we're surprised by it. I have no doubt that NHS England will be surprised by it, despite us telling them that this is what's going to happen. But it is one of those things. So it is all part of getting back to a place whereby we don't have too many cancer patients with.
I was also going to make a comment about the criteria to decide, because since I remember, we've been over 100.
Yeah, it's really
And
good.
so this is a really positive journey. And when you talk about assessing, not that I'm filtering outside people's offices, listening to their conversations, but Helen's office is opposite mine, and I do know that the kind of detailed conversations that are taking place, that's got you all worried now, hasn't it, as to what I'm hearing in office, but the detailed conversations that are taking place about each patient and really pushed out to kind of understand what that person's journey is going to be, can be, what possibilities are. I do know that there's a huge amount of detailed work going on that, and also thank you very much.
Almost to you about that. So from an elective recovery point of view, I think we all know the organisation is challenged, we know we're not where we want to be. However, when we got to the end of September, we had 688 patients still who had waiting longer than 65 weeks. That is actually 77 patients ahead of where we planned to be. And those plans really are challenging plans. So for the teams to deliver another 77 patients of a reduction of 77 episodes plans was really positive, and in no way it would not have happened, sorry, let me get the right English, without that very detailed scrutiny, that highly post-history reflective. In fact, I can tell you as we sit here now, there is a group of senior people going through line by line on this ratification at a strategic level. They will do that all the time. And I would be with them where I'm not here. So we have achieved that through both additional levels of activity and also theatre and outpatient transformation work streams that are now also starting to deliver on our efficiency programs. So there is a more number there around outpatient transformation in terms of our DNA rate being at 6.9%. That is a sustained reduction that we have seen when I first joined the organisation. It was significantly higher. We're also seeing a growing increase in patients discharged to what is referred to as patient-initiated follow-up. And we've hammered another clinician support, just refresh our approach to that, which will make us more efficient and effective in outpatients. So I think there's a double-edged sword when we start to talk about our financial pressures. And Jonathan and I have some very grown up, let me call it, but challenging conversations, because those two things are, there is a direct conflict now for us between how we maintain the significant levels of additional activity on top of our core activity and how we achieve our financial position of balancing both Gary and they are also very interested in. But I think the board seems pretty positive output from that, but it comes with a real cost. I think the final point I just want to make around elective recovery, as Joe alluded to, we've seen an improvement in the number that is reported and is often the benchmark, which is our 18-week performance. That's the percentage of patients who are treated or discharged treatment within 18 weeks. It has the end of September performance was 38.8%. How frustrating is that 2% to me, because I did unsketchable reporting, but anyway. And that's an improvement of nearly 5% over the past few months. So that's a significant step forward for us, and we will continue to push on that. But it is
hard slog for the clinical teams and the operational teams to get to there. And I'm really pleased that we got to where we got to in September. That is now an interim expectation that people will clear all of those backlogs, because we are not the only trust in the country that still have these long waiting patients, and we're certainly not the worst of the country or even worse than England. And we are working really hard to try to clear by the end of December. But I think the point also worth making is, as you get to a very small number of patients, they are usually your complex patients. They've gone somewhere else for diagnostics or whatever, and though clearing those remaining bodies with on target and are really kind of there's a kind of effort to benefit patients. But we are committed to continuing to get to that point and clearing both those backlogs and our trajectories include anybody that we need to into that category between now and then.
And I was just going to ask you, so when you talk about the challenging cohort, how big is that challenging cohort?
So for example, well, it varies, but for example, from a capacity point of view now, in most of our medical specialties, we would have 0, and we've, in some areas, we've got single digits of a few patients that have got to really have some complex. We've got some orthodontic patients who've gone through second opinion to diabetes and choices, and that who know how it goes. And that's not really happy. I don't show organization, that was just the way it is. So in most areas, they're single digits, where it's not just us providing capacity. But those, I haven't got figures for how many of the total ones. What I can tell you is that the cohort that was 688 is now 474 as of today, and continuing to reduce.
I think that's important because that sounded, even though I know the ongoing conversation, that sounded when you said Christmas or in December, that sounds like quite a shift, but clearly that is.
And that's the rate that we are moving.
Yes.
And shifting. I have confidence around an operational plan that gets us to 90. So I've got 90 patients. 90 patients I'm still working through.
I think it's good for the board to have a kind of a bit of a joke to that, accepting there's lots of factors.
Yeah.
Joe?
Just if I come in on that, so Helen mentioned explicitly the challenge between clearance of patients waiting a long time and the financials associated with that. The board will be aware, because we've mentioned it previously, the premium costs associated with treating these patients, recognising that we are using our weekends and evenings internally, and we are contracting out to external providers to do some of this work. The tariff that the organisation gets paid is insufficient to cover the total cost of that premium activity. And so at some point we will have to have a conversation about whether we can continue with that premium activity and continue to reduce longer waiters versus the consequent impact on our financial plan. And so I wouldn't want the board to think that we would automatically clear everything down, because there is a cost to that, and one that we have not yet decided on.
I think it's important for the board to understand there is today's cohort, but there is also the total quantum of patients that will tip into becoming a lot greater. So it is not that people get to the end of December and then say, right, job done. We will need to continue if we are going to at this pace in order to get through this time to support. Otherwise, we will start to go back. And looking at some of the national and regional data that there are some organisations where you start to do that. That's happening post the September deadline.
How did you have your-
So a question from me, Helen, I think we should go on the mayor touched on, and I'm just trying to keep my head on the flow as opposed to the end result. And I think my question may be misaligned and not sufficiently based on the knowledge, but my memory is that diagnostics been a big issue with impacting on flow driven by staffing levels and availability of kits, which will create a way to keep that volume growing. Sense. So I wouldn't mind an update on that. I know Fiona's touched on community diagnostics and very sorry.
That's fine, I'm just wondering where you're going.
Yeah.
So the first thing to say is that actually the diagnostic performance is adversely affected by the fact that the teams are working very closely together to first we prioritise cancer, as Jason, then we prioritise all the waiters. So that means that sometimes we're asking the teams to do the diagnostic test ahead of somebody whose overall pathway has not waited for. So that affects that sometimes. But getting diagnostic capacity is a core enabler to help us with cancer performance or and Ben and I were totally aligned on where we needed to ask for the cancer money, which was around the CT scanner and the pathology, because absolutely first priority will help cancer, but it will also have a significant benefit to our event. So those two things, you're right, I'm not sure they're an interesting question, but will you take it offline and get it?
Yeah, no, it was just due to an action plan to address those issues.
Yes, and that meeting I referred to has representation of all the diagnostic modalities, not everybody from somebody who's responsible for helping to get identified to somebody who's responsible for that MRI. So you can put all the teams together and try to all each month. But it's very low level.
And Jonathan, that project is on a serial one.
So we're just going through an exercise to really make sure that those costings are robust, based on what we know now compared to what we hypothesised.
Thank you.
Thank you, Phil. Certainly,
Yeah, just to follow up on that. So I think the other important thing is obviously we've got this money that will help us get through to the end of March, and then it's just so what. So we'll need to start thinking about that.
Where did this money come from? I kind of missed that.
It's cancer money, it's national funds.
Oh, national
That's
funds.
been committed to committed for cancer.
I was listening now. I was trying to say no. Additional.
And came in this week.
Okay.
was your client letters.
Okay. That's good news. Now we're clear on that. Thank you.
Thank you both very much. Really challenging position remains, but it's very good to hear the steps of progress that we're making. We're going to take a break now. We're a little tiny bit behind timing, but not massively, and we'll pull that back. So if we take, it's 11:37, if we take 10 minutes exactly to 11:47, I think we have break. Thanks, you. I think we've had some good discussions so far. Welcome to Jonathan back in the room. Delighted that you are here in person and on hopefully on a good trajectory. Let's talk about trajectories. I'll hand over to you to kick us off on the finance report.
Yeah. Okay. So as usual, the paper has given reports and position financially in September. Just to draw out key headlines, but more important, draw out some key risks, some of which we've touched on during the earlier part of this meeting. So in month 6, we delivered our first surplus for the year. Obviously, that was 8.4 million. That takes us to a year-to-date deficit of 4.6 million, which is a driven plan by 6 pounds. So going largely in the right direction at that point, we continue to forecast break even. As per previous months, that's predicated on delivery of additional activity income, sorting costs to plans levels. Touching on already today in terms of SIP, I think we've still got a little way to go. We've made some incredible movements to touch it. We're going to deliver somewhere around the region of £20 million this year as an efficiency improvement, which still a chance to deliver, but is a significant improvement for this organisation before, so lots of people have contributed. That's helpful. There are still significant risks to delivery of the plan, but so obviously delivery of that fuel simply is amongst those. But other key risks we've got, Karen touched on it earlier, the accounting and coding issues we have, that has the risk to derail some of our forecast delivery plans. ERF payments, some of you might have seen in the press suggestions around the caps on that and like over the rest of this year. We have been fully assured by NHS that on a number of occasions we will get paid for the activity we have to take. So we have that assurance, but the way that plays in terms of payments, it comes in arrears to the last year was expected. I think clearly the biggest risk of messaging, Helen and Joe, others have touched on already, is the premium costs of elective recovery. And it's very clear there is no additional money available for NHS England. And touched it, we are undertaking reviews of all of those additional capacity initiatives we put in to make sure we're clear about what money they are costing us and what they're generating in terms of additional income. And we're having a review of that at the moment to make sure we clearly understand.
Can I just check that you're on sharing?
Sorry,
No, that's fine.
okay, I shall.
Excuse me.
No, it's
My
don't
old age,
worry,
you
I'm
know.
talking to my book. We clearly need to make sure now that where the demand is ongoing and will be for the foreseeable future, we need to consider how we can organise the cost there to regular capacity. So that's probably one of our key focuses. And as Joe said earlier, some of these initiatives, here we are losing money. Therefore, there needs to be difficult decisions made around how we balance off the priorities of finance. So clearly, that all remains the primary, I'm thinking, and will be a challenge for the rest of this year. In terms of escalation capacity, it has presented a challenge on plan, continues to do so, but we've made some significant strides since Bose arrived. Bose is saying that escalation capacity, which is really positive and is directly impacting in terms of our run rate of expenditure. New risk, whether this risk is yet to be established, but the K award, which our staff was communicated as being fully funded, but in common with a number of other trusts at the moment, there is risks around whether that has generally been fully funded. So we are working through that with ICB and NHS England at the moment, and there is the potential to be a risk proposition nonetheless. The report references to our position, our capital position. We're on track to spend our full capital allocation this year, making sure we don't waste any of that money. As the final thing I'll say is we're now starting the process with regards to 25-26 planning. It feels like we only just finished last year's, probably into that work now to make sure we're ready for next year's position. We fully expect our efficiency asks will be very similar to this year at 5-6%. So I will pause there, step questions.
Thanks for Jonathan. You've done the same.
From here,
I think it's not for answering here that question really around what does ongoing good performance or treating patients, moving lists, potentially cost is kind of the nod, isn't it, of the many factors that Joe referenced earlier, much earlier in the meeting, that we will balance, and I think that's a conversation for Vic.
I agree. I think it's really
clear. Policy committee to some extent. Yes. Yeah.
There's a natural tension there, which means there needs to be some element of prioritisation. That's the challenge we'll have to bring those committees beyond.
Except I don't know the execs do think that, to your point, they will go on having the waiting list if we don't tackle it. They'll go on having the long waiters. Constitutional standard of 18 weeks won't be even in our sight line if we don't at some point get ourselves back facing in a green light position, even if that's with a certain number of complicated patients and on a long waiting list. So no, that this is John. I knew if I answered that, Joe would do a face that he was going to consider what his response would be.
I suppose the first thing to say is that we recognise that we are not as efficient as we could be.
Mhm.
So I think we need to be clear that this isn't just throwing our hands up and saying, we need more money, there's nothing we can do. This is not what we're saying. And we can see throughout the organisation, the efficiency of the organisation improving. So over 80% utilisation in theatres, significant reduction in the number of cancellations, improved numbers of appropriate patients in our beds. You can see those efficiency metrics getting better. The and for me, which is where I think we are really going to be challenged as the board, is are we prepared to pay premium costs to reduce waiting times quickly, or do we continue with our efficiency drive internally and recognise that it's going to take longer to reduce the waiting times? I think that's the decision, not that we're going to stop reducing waiting times, but it's the time that it takes to reduce those waiting times that's the real challenge.
So it's not a question, it's not a version for us to discuss, but in my experience, businesses, one of the questions is often, putting the point you made in a different way, are you better off spending money today to get the backlog down, because the steady state is better than more absolutely managed. So your ongoing running costs reduce significantly. Whereas if you live with the backlog for longer, there's often a knock-on effect to that acts in lots of other ways. That means that you actually end up spending more and taking some short-term pain. And the real question for me is, what's the one-off? You know, and I don't need an answer now, but that's how my brain will be thinking when that debate comes up.
And I think that's to your point, the point Gary raised is how do we have that conversation, isn't it, to understand that? And to your very earlier point, that there's multi factors in this that other people are looking at.
Absolutely.
How do we tie that all together to the right best decision?
Completely.
Yeah.
Completely. And then the variables that change out with our control, irrespective of how clever we think we are being.
Anything else for opening into conversation? That's great today, Jonathan. Thank you very much. Well, of course.
So I'll take the report as read. What you have in your pack is the overarching dashboard of the European University and actually that's 12 months. What we'll do is just pick out some breaks from the report. So firstly, temporary staffing, that remains static at almost 5%, so just using 5%. And bank usage is the biggest driver for this. As we touched on earlier, we have our team within HR looking at specific hotspots of improvement to look at how we not just find ways back into substantive pace, but also recruit substantively initially in the first place. Also, staff absence remains just below the target of 5%. Turnover is just above 13%, which is higher than our target of 12.5%. However, that is lower than this point last year. So it's moving in that direction for us. Staff mandatory training is above compliance, and appraisal rates are also above compliance. We had a focus particularly around summer periods around appraisal rates because there were staff just dip almost down to the target level. With that renewed focus after the summer period, we now see that rise again to 93%, which is really good places to be to these months. I just want to pick out two key areas that I'll touch on continuous improvement. First, there is projects underway around payroll, so we're looking at underpayments and overpayments. And because of that, we see increased visibility around that. What you see is that played out in the actual that you have that increase in the numbers in there. It doesn't mean we suddenly had an increase in pay errors, it just means that now we're implementing a load. So in here. Also just culture panels have been implemented and currently trialled throughout last month and this month. And these panels are made up of clinicians and also HR team, and they're designed really to be that first point for disciplinary procedures to look at the context in which the instance of the issue is taking place and to fully consider several factors, so six key different points around that early point. What we're also intending for through that process is the process gets underway much quicker. And much of the feedback that we've had previously, and it's not just Kings, I think it's university around HR processes in the NHS, is the time it can take to get the process underway and what that means for the person being running that process. So it's really important that this implementing these panels will help to put in place those investigation teams really quickly so they can get away. And also just to have a legal update, which that the end of the report, so the 26th of October, as an organisation, when I'm subject to a new preventative duty to take preventative steps to protect our employees from sexual harassment. So we will be looking at our policies, refreshing our policies in light of that. It's going to all to be aware of that change in the Equality Act, those standards in organisation.
That's not a question, really. It's a comment for me because we've heard an awful lot about pressure in the organisation and pressure to get our patients through, like to recovery, etc. And I think what's really stands out to me in a positive way because they just first things that deteriorate in their developments are our appraisal rates in our training, which I think are exceeding good, and I think are a really positive indicator of leadership at all levels through the organisation and our positive spin. Sorry, not spin, but the wrong word, that positive focus around staff development. I just think we should really be aware of that from our team and the organisation to achieve those rates.
I think that sense when I was thinking about it, and the thing that you've talked about you want to achieve is that if you can, we can engage them on those that level, we can engage them on other things, and it'll be about saying what does that look like, and therefore it's important.
Question for me, from my we're looking at the overall stats, I'm actually interested in those key bottleneck roles that are implementing flow. It could be two people that can focus on recruiting that can make a disproportionate difference to how the patients flow through the organisation. So it'd be good to get a handle on that. And the second thing is, sorry, I don't know, it's just going first. The second thing is I'm conscious we put a lot of time and effort into recruiting some brilliant people from all teams. This is in midwives and putting a lot of effort into retention. And again, that subset of how we getting on that, because it's certain people may have that need on.
We did report back to board on that, I think in
It was a little while ago,
April, so maybe we come back, wouldn't it?
So I was
Yes.
just mentioning it.
Yeah.
So
Yeah, no, I think we're good.
that's all.
Other questions for Dr. Hader?
Thanks, Catherine. And two questions really. One is around the additional professional and technical, which is really high now. I think it's always been quite high, but it really seems to be kind of hitting the ceiling. I was just wondering if you had any background to what's really driving that number, and then shall I wait for my second?
Yes, and it might be that other colleagues will come in as well, some professional areas, talking success approaches to work with plans. Certainly health sciences those areas are difficult. They're difficult to work with this national justice and many of those. We have had conversations with the system also this conversation to around action costs geography because, you know, there were rebels and all this kinds of things in all of our organisations locally, but it is a real challenge. And working with Fiona, looking at skill mix, looking at making our teams, to look at the community, but we have to provide those associated where they need to do that. And I feel like Fiona.
Yeah, so I think it's a really interesting question, particularly about some of our healthcare scientists, our health professional staff, where we have higher vacancies. And what I see and what I hear across the system and wider nationally is a movement that these are really, there's a small number of roles. It's not like nursing where you've got high volume, you've got a small number of roles that trusts cannot survive without people in that role. People will leave and go work agency where they earn a higher salary. So therefore we still have the need. So that people are coming in on agency to fill those roles because that's what we need. Nationally, it's a really wicked problem. With nursing, it was driven very nationally that from July this year, we all had to come on framework. And I know that there's some work nationally going on, looking at a similar approach for allied health professionals. Because it is a problem that actually, if you go out and you come and work for agency, then you will receive a higher premium than you do coming in on the agenda to change terms and conditions. So it's something that's being looked at nationally.
So it's a takeaway, but I mean, this has been high for ages, it seems, higher than I ever remember it.
Yeah,
but is this just something that we have to live with? It's a qualification.
I think that, so I'm recently new to post, and it is something that I'm working with Jamie around looking at our AHP workforce and what are the things that we can do. We have looked at whether we have some higher grade roles within the organisation, but it's really important to bring people in that will change job description and that we're not paying people at high grade to do a low grade work, but I'll hand it to Joe.
I think the other thing that we've seen is a real impact of some of the national directives around recruitment into primary community care that have directly lifted professional AHPs out of acute care settings sort of into primary community care, particularly around pharmacy. And we recognise that we are not in a position to match the sort of roles that are being offered in those private community care settings. So that's had a massive impact on our workforce. And we are trying through training, education, recruitment, retention pieces because of the national pay framework, and it's not easy. So I think we'll continue to try.
And we are having some success. So in the start report, it did show that physiotherapy was coming down, the occupational therapy was coming down, but so we are having some success in some roles through looking creatively and differently.
We just don't want to get a bit.
Yeah.
Can I just add to that? One of the things we have looked at and has given limited success, but success nevertheless, is looking at roles that we can't recruit. The roles have educational component where they develop themselves, and that's become much more attractive to people. So some kind of possibility of education improvement attached to roles. Success.
Thank you. There's no further questions. I'm going to move on. Thank you very much. So assurance and statutory items. We'll try and take these as succinctly as possible. I think. How do you like your stewardship?
Yes. So that's an annual report. You say I think it is read. However, there's just a few things that take out to the information from my building stewardship team and work around the clock to try and improve our use of antimicrobials and reduce the broad spectrum use. They do weekly. They do twice weekly ward rounds across the trust. They do daily ward rounds rather in hotspots and including ICU. And they've achieved the sequence target for the conversion of IV to oral in this year, 2024. So that's really interesting. To bring out just very quickly, although our total consumption of antibiotics in hospital has remained lower than the national average and comparable to our peers, in the last sort of 2 quarters, the use of the World Health Organization Watch and Reserve category, which is a broad spectrum, has increased quite a lot, partly due to increased acuity and partly due to the coding issues and some of the denominator changing. So that number is going to be a little bit variable for a period of time until we've sorted out that coding issue. And that's just time on there's an uptick to our use of these broad spectrum antibiotics, and partly that's related to the COVID changes. The other thing just to bring out is, again, due to increased acuity in patients and the numbers of patients that we're treating in the trust, we have had a little rise in the multi-drug resistant organisms in hospital. This rise is a significant threat to antimicrobial stewardship in the years ahead. Just to be aware that that initiative is pending. And then finally, a good news story that the MKUH AMS group, stewardship group, have created a partnership with the University of Nigeria Teaching Hospital following a successful grant application from the Commonwealth Pharmacists Antimicrobial Stewardship Scheme. So that's a mouthful. And this partnership is working at generating awareness and improving antimicrobial stewardship in Nigeria as part of the World Health Organization. So that's really positive.
Really good to see the big work that's taking place in the week. Has anybody got anything they would like to ask on that report? Thank you very much. And I think we stay with you.
You do, yes, indeed. So I'll hold on here. So this is now the Infection Prevention and Control Annual Report. And I have to thank a couple of people. One of them has just come back to help support the team as authors of the report. So this is a team that's really struggled in the year. At one point, all the posts in this very small team were anticipated to become vacant over a very short period of time. However, we've rolled back from that position and still have some vacancies, but certainly we have a team that's functioning and functioning well. And we've had one of our former deputy DIPC individuals coming back to support some fixed-term support for the team, and that's been very valuable. And just to say, in the year, MRSA was at 0. There have been a few cases of MRSA since April, and looking through those, we haven't seen any significant MRSA spotted here, but obviously those are being reviewed. Most other recent reported infections have been pretty static compared to what we would have expected, and that's despite the fact that MK has seen lots more patients and obviously has an increasing Asian population. The levels of C. diff have increased slightly in line with our experience amongst our peers locally, and most of those have come from the community. And obviously, we look at those with our scrutiny as well, and those reviews are ongoing. We do that with some each time. However, from the brief outlines of the reviews, it doesn't look like there's any major acts of omission that have occurred with the spikes of localized C. diff infections. So overall, not an outlier, and overall the team is functioning despite a lot of challenge.
But I just confirm from what it says here, so the review of the national increase is a national increase in C. diff. Yeah, that is what that's saying exactly. Thank you. Any questions on that? Gosh, it's his first proper meeting. We should at least be interrogating him for some elements of the report. It was very clear. Risk management. Kate, I'll hand to you.
Thank you. So just briefly, the risk register is the supplementary shelf with all of the risk scrutiny. This pack went to just effective committee just yesterday. So at that committee, we agreed to put 3 new risks on the corporate risk registers. They are IT related risks around staffing and some system issues. There are risks that are being actively and practically managed by IT. I don't want to discuss them in detail here. They are being managed very closely. But happy to take any questions otherwise in the report. So relatively, it's as always with the risk register, it's a bit of a ledger report. It's what's come on, what's come off, and it's just here for sort of scrutiny really.
No questions, Kate.
Thank you. And then the board assurance framework. Similarly, we've got a bit of an overview of risk profile across the system. As I mentioned before, we are working on system-wide risk profiling, and that work continues, which is really positive work. Obviously, we had a seminar on risk last month, and the board assurance framework is just being updated to reflect those discussions. So it will continue to change over the next.
At that meeting last month, I think, and I may be remembering wrong, we asked ourselves a question about risk appetite and where
And we need to do that.
we did. That's fine. So we've got that on the list. I couldn't remember where we left it. Yeah. Other questions back. Obviously following on from last month's quite detailed conversation, and we're going to match it up as we go forward in terms of the strategy, aren't we?
Yes, that's right.
Yes,
Yes. So there's lots of work to do sort of between now and March.
Excellent. Thank you very much. That's lovely. So moving ourselves onto the terms of reference. Now there's a lot of those in here, so I don't think I'm intending to take us through each of them in turn. If anyone has any questions, I think we could take any questions that anyone has.
Just one proposition to change the title of the audit committee to audit and risk, and to Broadlands. It's remade a bit more in its terms of reference.
Is everyone supportive of that?
Can I also take the opportunity to make sure everyone's aware 4.4.3. Actually, it's 4.3. Sorry, so red text. But the Audit and Risk Committee will receive evidence-based assurance from the chairs of the other committees. So that's something that we always kind of expected, but it was never articulated specifically. So I just want chairs of the other committees to be clear
of that.
Be happy with that.
And that might be people being requested to come to a specific meeting rather than attending 4 meetings.
Absolutely.
The question I was going to ask is whether it would be appropriate for this set of change of terms of references to go to said audit committee as a process. Because I think in terms of individual oversight, you've done it, but then we could say that we have done appropriate oversight through our audit and risk committee.
Yeah, I mean, the audit committee is subordinate to the board, so this would be adequate in my view, but there's no harm in going back.
Yeah, but in future.
Yeah, but absolutely.
Thank you. Anything else on those terms of reference, Kim?
Yeah, I just wondered how others felt about the visibility of quality within the terms of reference. So I know that our agenda goes through and quality is thread through all of our reports, but I'm just curious about whether we should reference that more explicitly within the terms of reference, that quality piece is thread through everything, as opposed to it's not on the agenda as a dedicated item. Does it come through straight through? So I just wanted to.
So I think interestingly, there's so this is obviously an update of our terms of reference, sort of holistically as part of our combined governance housekeeping. But Energies England have published some insightful forward, some new guidance, which Kemi and I will spend some time working through around making sure that we reflect that newly published good practice. And I think that might well pick up sort of things about how we balance our agenda and whether we've got plans right and we can challenge ourselves on that and quality perhaps the reporting to
present. But I don't want people to think I don't see the quality because I do see the quality come through and I'm sure it's here, but the visibility of it. Others.
I think it's a good question. I think one of the conversations we've had with Sarah as chair of the Quality and Risk Committee is how we make sure we have enough of that at the committee to assure the board. So I think there's going to be a journey with Quality and Risk Committee over the coming months with yourself being with the wider team about how that is.
Also, in response to your query, my conversation with Ian was that the Quality and Clinical Risk Committee in terms of reference will still come back to this board outside this approval. He's just waiting for it to settle into post. And then in February, for the discussions that they had, both of you will sit down and give other stakeholders to fine tune the terms of reference the way you want it to. So we're still bringing QCRs together.
She's fully settled. Excellent. Thank you very much. Kate, you sort of see it.
It's just here for formal ratification.
Approved. Thank you very much. Forward agenda planner. Are there any comments on the forward agenda planner? No. We have. I'm looking at sheet. We have 2 questions from the public, but one was around the healthy food options on the site of the hospital. We did answer last month. In fact, we answered, I think, the board meeting before. So here we have a very detailed response in terms of the options that there are for people in terms of 25 hot main dishes, 14 sandwich and homemade salad options, 15 hot and cold desserts, and also they will be introducing fresh homemade soups. And our new meal service system, Simplicity, has reduced the system food waste from 16% to 2%. So I think we're noting those comments again, that we continue to work closely with hospital dietitian and also the broader catering team to make sure we have a really healthy proposition across a wide range of food options. And then the second question was, can you confirm the news on the Women's and Children's Hospital and how it is to be funded and how efficiencies are to be made in orthopaedic surgery? And there has been an answer written here. I don't know if anyone would like to kind of verbally comment on that.
I'm very happy to take board through it. We have received approval for strategic outline case, and we are now working on the next phase, which is the outline business case, and we've received funding for the first few months of that. We're obviously waiting for the results of the government review, which is due in January of the new hospital programme, which we believe should set out timescales for the new hospitals to be built. In the meantime, we're obviously cracking on with the Oak wards outside Oak House, that car park area, which will provide us with some additional capacity until the new hospital is built. And we are looking at how we use our theatres over the next few years to make sure that we are able to accommodate not just orthopaedics, but all of our surgery as Milton Keynes as a city grows. So that planning is underway.
That's a good question. So just before we close the meeting, I would just like to say a formal thank you to Dev for all of his hard work and commitment as a non-executive director, and being a fantastic colleague to work for, particularly for your chairing of the policy committee. Really sad to see you go, and I know you're perhaps going to have a break, but I have encouraged Dev to consider where he might find NHS system or trust or organisation to support in the future up in Birmingham. Thank you very much, and it's been an absolute delight to work with you. There will be a card, but I'm waiting for one more person to arrive and sign it. So, okay, I think we're done. I motion to close the meeting. Thank you very much, everyone. And we somehow managed to find ourselves slightly back ahead of schedule, so that's really good news. So we're going to take half an hour for lunch. So if we could be back here at 5:02, that would be really good, because then we'll start promptly on time for part 2. Which we are going to be with Yvonne.